SSD rendering appears is available in this volume viewport only after you have saved a tissue or done any segmentations, or if you have loaded any pre-processed result with tissues and you have enabled the tissue over here in the tissue management, this SSD rendering, you can actually visualize that particular tissue in this fashion. So a volume of that tissue can be seen like this as you want. And okay, there are some more tissue segmentation options over here where we can draw ROI or fill export. You can even do some volume calculation. There are various test cases that we have executed in past, and also you can see the volume has already appeared over here. And if we want, and we can even expand or increase the volume, decrease the volume, fill explode, all these things, tools we can do. And this accumulation, this if you want, you can, this has actually created another tissue upon this or something like that. Accumulation over here. There are such tools, various tools that we have over here. And the fusion, this volume explorer, by the way, was the first tab that we first saw. So other than that, Fusion is most useful for PET CT scans. Actually, when you launched PET CT data onto CT viewer, you can that concept of underlay, overlay. So the color maps for that, and you can actually do the correct correction of the registration, how the PET and CT are correctly aligned upon each other in the volume as well as on the MPRs. You can do those corrections using these tools. And if you want, you can, there are various this color maps also. If you want to differentiate which is PET, which is CT.
Question.
Yes.
For what modalities CT viewer is validated? Is it also for NM and MR?
Yes, we can use CT viewer for NM and MR. Not exactly the NM planar or the SPECT ones, but PET CT is where CT viewer can be used. Of course, for PET CT or NM, most often it is NM viewer, or nowadays the Mirada, which is more recommended.
Yeah.
We also have the erstwhile NM viewer also still available in ISP, but that's the one which is more used for NM, planar, all those SPECT, PET CT, etc. But CT viewer, of course, is more used for the CT and MR. Yeah.
But the question is if it's validated, if we allow, officially allow the user to use it for MR, for example.
Yes, we do, because even in, I think, our IFU or all those documents, we have mentioned that it is supported, all these modalities. So yeah.
In the past, we haven't. We need to be careful about it.
Okay. And by the way, if you want, you can even do some visualizations here also, that there are some additional tools like the glass view, all those transparent. These things are the small things which are part of this volume. And okay, now let's go to the last one, which is endo. Endo is just, of course, as the word says, inside the body. So now here since I did not draw any curves or anything, so it is just scrolling up and down. So you can see the arrow also in the reference viewport is just going up and down. But in case if I, for example, let me draw a curve so I can show you guys. Let me just draw from okay, let me just draw across this aortic arch from this behind. Okay, so if I just switch to curve tab, select the curve, and then I do the play, you can see how it has actually little play from that flow. You can see in the reference viewports also the speed also. Let me adjust a bit faster. Yeah. So you can see slightly there are some plaque here. This one calcifications here and there. So this is how this endoscene is useful. Okay. Other tools, of course, are very common across all these line and 2D ROIs, angle, all that. These are very common things. I need not cover that, I think. And even these functional tiles and all these are very common. And of course, the usual, say, film and report and bookmark. Of course, you guys will be familiar with that. Let me exit CT viewer. Okay, let me go to now some CT cardiac applications, because CT cardiac is also very common in the cardiology, firstly, of course. So one of the most used CT cardiac application is comprehensive cardiac, CCA, that we call comprehensive cardiac analysis. So that's more for the analysis of stenosis and all that, and even the functional cardiac CT. So let me just launch a bookmark again of CCA. Of course, for CT viewer, I launched, I saved a bookmark of all the faces, but for CCA, I did not save launching all these faces, because anyway for cardiac, if you're aware, it's more of analysis based on the that is systolic, diastolic, and diastasis. So that's why I took the main 0%, 75%, and 40% phase, as they are mostly used for us the cardiac analysis. So let's just wait for a few seconds. Yeah. So of course, in almost all CT application, first stage is always the segmentation, where the algorithm runs and it actually segments the respective desired anatomies. Like for example, here in CCA, you can see once this loads, you can see that segmentation in this heart segmentation tab over here in the left. This tissue list, it has actually already it has segmented the parts of the heart, the ventricles, the atrium, the aorta, and even the coronaries. So since I said that stenosis is one of the most important analysis that CCA is used for, so that's why the coronaries. What is coronary? If I talk about from the clinical standpoint, the vessels that actually are surrounding the heart, which actually helps the heart to beat, because of course heart supplies blood to the rest of the body, but of course it also needs blood to function. Otherwise there'll be many issues like in the myocardium or in myocardial infarct, and what so many are there, cardiac related diseases. So if there are any blockages, any stenosis in these vessels, so the corresponding part of the heart might damage over time. So it's always better that if these vessels are very healthy, these coronaries. Why the word coronary? Quite, I mean, interesting question. Is that because if you turn it upside down, it looks like a crown. That's the word. That's why the word coronaries it is called. So yeah, this is the coronaries. You can see it is which actually surrounds the hearts, and so the segmentation stage, we can just, I mean, if we see first thing what we do is in the segmented heart, you can see that this red part, these red overlays are the ones which are coronaries actually, and the pink one is the aorta. And because what's the purpose of the segmentation stage and these tools is because although algorithm is efficient enough to segment as many parts of the coronaries or whatever, but sometimes if any reason, maybe like if it is the particular new version, if for example if Siemens introduces a new CT scanner and unfortunately it's not under our coverage of multi-vendor support, so it's possible that it might not be able to segment completely. Some vessels might be left out here and there. You might come across certain issues related to that as well. So for that, of course, if the best desired by the doctors are that the algorithm is self-efficient to segment all the vessels, but if any vessel is left out, you can see some vessels over here which seems like it is going out, but okay, it's not segmented here. Something over here, gray spot you can see here. Yes. So what we can do is we can do an add coronaries. So we can place a seed point and it'll see it has added some more vessels over here. You can see some branches that have come over here, which were not there before. Yeah. Yes. So that's what it is. This tool is add coronaries, and other than that, of course, smart segmentation tools, all these are common tools, of course. But even, I mean, sometimes even doing this manually might not help. And if they feel that what they did actually is they've just doing this add coronaries, they have screwed it up or anything. So they also have option to reset all, but if they instead of because since multiple phases that they work on, and I've just taken 3, but there are many cases where they have taken up to 15 phases of heart. So if they have to keep analyzing everything one by one, it's very time consuming. So they can, I mean, to fix it, they can even do a resegment. So they can mark any seed point, and they can even choose to resegment a specific phase, which is like the current one, and then do a run segmentation. So that's something which is very limited. This much is the segmentation stage in the CCA. Of course, the bookmark, key images, batch, these are very common tabs I don't want to talk about. And since I launched, even the whenever we are selecting a CTC, this particular data, for example, this also has ECG series. So ECG, also we can have a look, and the ECG waves, the beats per minute. So when we navigate through the phases, you can see that this red marker, so this white indicator, it actually is positioned accordingly at the particular wave of the heartbeat. So accordingly, you can even analyze with whether the phase which we have mentioned over here, is it correct? As in, is it actually 75% or is it 70%, 80%? It's quite, sometimes it's chances that because these phase labels are filled in while the acquisition is going on, chances are that sometimes if either the scanner is not able to recognize, or if the radiologist or the technician, they couldn't recognize the face correctly, so they can actually rectify that also. They can, I mean, later on relabel or do anything, the icon change. But most of the time, of course, they are experts. Most of the time they are experts, so we cannot complain. Okay. Okay, next stage. Now, most of of course, since you saw that City Viewer has scenes like this, separate buttons over here to navigate. And yeah, by the way, whenever we launch these applications like Comp Cardiac, which is, so we also have additional CT Viewer. There's another CT Viewer that is available in ISP, which is called Cardiac CT Viewer. This is, of course, like a doppelganger of that. It looks mostly the same, but it does have certain tools which are additional. Like in CT Viewer, if you remember, the faces, I launched the same study and all the faces were there, but they were listed only in the series tab. They were not arranged in this tab fashion over here, just like how we have in CCA, right? We have the faces are arranged in a tab fashion here, but in CT Viewer we don't. Cardiac CT Viewer we have, and certain tools which are only limited to specific to cardiac CT Viewer are like this rib cage removal and all that. So when, I mean, I launched the bookmark, otherwise when we are launching cardiac CT Viewer, there will be an algorithm which will run as rib cage removal. So certain tools are there which are unique to these applications as well. So like Magic Glass is not there in CT Viewer. And this also has this functional analysis where you can actually have a look at the HLA, VLA, and short axis angles at the views of the heart chambers. You can do that. Even SET-TD, all these things are there. You might have come across that yesterday in the MR cardiac. Yes. So similar things are here as well. So okay, let's just come back to CCA now. CCA, mostly all these analysis applications, they don't have such buttons to navigate, because most of the time it has to be like once one stage is completed, you have to navigate to the next step. You have to follow an order in the analysis. So that's why we have now in CCA, it has 4 stages: segmentation, coronary extraction, coronary analysis, and lastly is the functional. Now, what you saw in the segmentation is that as a whole, all the heart parts of the heart and coronaries as a single tissue, it was shown. But next stage, which is coronary extraction, now these so many coronaries that we are seeing, each of these branches have their own names, like LAD, LCX, so left circumflex artery, right coronary artery, left anterior descending or something like that. There are many such vessels are there, and algorithm actually recognizes these vessels also individually. I mean, automatically it does. So you can see that for each phase, sometimes there are, if I navigate through these phases, some vessels are not visible for the reason that because heart has so many chambers, right? So many tissues are there. So some of these vessels might hide behind these vessels, these heart tissues. So for that reason, some of these vessels won't be visible for all of them. Like if I go here, like 75%, it has, you can see like this doesn't have D2 or something like that. You can find certain differences will be there. So that's the reason why we have to do this acquisition in multiple phases. That is, all the phases have to be acquired, and we cannot just have one single series of heart. Heart is, since it's a functional organ, it is a moving organ. That's why. So that's the reason, and even for coronary analysis also, we have to make sure that we acquire in such a fashion that all of the phases are acquired individually. Of course, there are, of course, this study which I have taken, this has each phase acquired separately as a separate series, but we also have cases where we have all the phases in a single series itself. So those phases also, the phase alignment we do, the application does that phase alignment. So we can actually, when launching, if it actually, there's a pop-up window that appears which lets user decide which phases do they want to launch. Because since the series, at the series level, like how we saw in patient directory, we had so many separate phases, but what if it is a single series is there which is having all of the phases, but it's not, you're not interested in all the phases, you just want the systolic, diastolic, and the diastasis. If you just want that, so that pop-up window will give you that liberty to select, just uncheck the ones which you don't want, and you'll launch only then. Of course, that will save all your time also, because otherwise every time if all the phases launch time also will be more, obviously. So yeah, let's come back to this coronary extraction. So as you can see, each vessels are labeled, but it is user's responsibility to confirm because if algorithm couldn't recognize that particular vessel correctly, so they can actually confirm, or we also have some preferences, so that if user trusts our algorithm and they don't want to spend more time in confirm vessels and all that. So what we have is automatic confirm vessel labeling. Automatically disable vessels label confirmation workflow. So such preferences are available, and of course, when we are now, if I, for example, let me just show you one thing. We can confirm vessel through many ways here. We have an option over here. We can even do it from the volume viewport, or if I want, I can even do it from the context menu here. Confirm vessel, particular RCA, for example, vessel here. Or another way is through these buttons over here, the save, filming, or reporting. If I just click that, a pop-up appears, and do you want to you confirm and then save. Things like that you can do. Confirm, label, and save. I do, and it'll confirm. So things like that. But here also this preference, what it says is, because again, so many pop-ups, so many warning messages. If a user doesn't have that patience to attend to so many warning messages, they can actually do this automatically confirm vessel labels when saving, filming, and reporting. So we are actually giving this check mark. But of course, here also we are throwing one warning that do you agree whenever saving, filming, or reporting an image with a non-confirmed vessel label, the vessel label shall be automatically confirmed. So such things that's why our ISP is actually full of such warning message, but that's actually necessary when considering the hazard aspect, the risk analysis. RMM, that's why our RMM also it's very huge. So yeah, now so many vessels that we have, and user might want so many batches, since batch is also a very common tool. So just imagine, let me just show you one example. I'll just take 175% phase, and I have to save a book batch of say these particular images, these that is, for example, this cross-sectional or straightened MPR, or this CMPR over here. So every time, just imagine I have to select this vessel, select this viewport, go to batch, define the batch, and then save it. Tedious, isn't it? Just imagine if I had to do the same exercise for each of these. You have to select the viewport and do that, and you have to go back and again select another vessel, and just imagine it's how time consuming. So how to make users' life better over here? We introduced a feature called multi-batch. Multi-batch, what we do is it is actually this tool is also there in AVA application. Now after my session, in the second half of the day, you'll meet a presenter who will explain an application called AVA, Advanced Vessel Analysis, where this actually came into existence before CCA. So here what we have done is, in this multi-batch, since these are the common vessels which we have, LED, LCX, RCA. So even by the way, here we have something called we can, because most of the time, sometimes users might not be interested in all of the vessels. So we can actually let user decide which vessels they are preferring to actually extract. Like if they don't want to extract the smaller vessel, so we can actually, here we have a present this one preference in the segmentation stage called show preference. So if we do this, preference setting will come where you can actually unselect which you are not interested. So on that basis, here in this one multi-batch, what it does is it actually has a list of all the vessels, even if there's no OM1 or any here in this particular 75%, but there might be OM1 in others or everywhere. So this actually here, if you can see this list, this multi-batch dialog, you can see we have defined this list, actually all these vessels which are there. But you can see that they're all grayed out. This generate button is also grayed out. Why? Anybody can answer? Why is it grayed out? Because the vessel is not confirmed. Since the vessel is not confirmed, so that's why that's the necessity that you should actually confirm the vessel before actually deciding to save any batch or anything. That's why even the warning message was thrown, right? Yes. That do you want to? So we can actually, that's why even everything we have kept it as grayed out. And if these are, of course, you can see that for each of these vessels we can actually generate a batch through multi-batch for this curved MPR. Let me scroll down and let me show you that there are more presets for straightened MPR and even the cross-sectional. So all these are there now. How are these? You can see that corresponding to these names, what particular viewport you want, and it has actually labeled as the particular vessel also. So for each of them, you can actually save curved MPR, whatever you want. But if you are interested in more kind of so there's something called you can actually even define your own presets. So these are factory presets for curved MPR, cross-sectional, and straightened MPR. And you can see that here the group name you can see as multi-batch for all vessels it has given. User can actually define their own presets. So there's something called manage multi-batch. Here through this dialog, you can actually go here directly. You can click here and then, or this manage groups option is there. So this actually is showing you how the factory presets are given and what are their parameters. Now you can see this batch type and this degree, number of images. These are also there in the regular batch tab as well. Same parameters are available, so they can actually define their own presets. Let me just create one and show you. Like, let me create one new group. I can actually add an existing preset from this list. Add existing preset. I can just to this particular group, I can reuse these presets also, or I can create a new preset. Yeah, okay. So let me just create this like straight MPR scroll or something like that. So let it be for all the slices or anything like that, and all the vessels. If I just give, I'll just layer on. I'll just show you guys, and I'll do an accept preset. Or I can even, by the way, if we create a preset, I can actually delete that particular preset or just remove it from this group. We have all these facilities, and this new preset also gets added into this add existing preset list also. So let me just do the save changes. And if I do this multi-batch again, this group is added here, and so is this preset added here. Let's just do one thing. Let's just confirm one vessel and try to do a multi-batch. Okay, I'm not going to use my preset. I'll just use the factory preset, and you can see that now that I have actually confirmed one vessel as RCA. So only the RCAs it has actually enabled, and automatically it is checked as well. So it is the straightened MPR, all of these, the correspondingly in this group, it is checked. And so let me just do a generate. And of course, this pop-up will appear. Where do you want to save? Packs, anywhere you can save this. So whilst what it does is the saving, even in the regular batch, you can see that when batch is being saved, right, it actually takes more time to process, and then the save dialog comes, and then again it saves. So imagine how much time is actually wasted, almost 6 to 7 minutes per phase, if I have to say. If I have to spend, just imagine then how long, and doctors have to spend days together with so many patient studies, and if they have to spend so much time for one study itself, that will be really exhausting. So now that you can see, it has, while we were talking, the screen did not actually didn't get logged or anything. I can actually continue using when the saving actually, how it saves is actually it follows this pre-processing path, how we have, right, queue manager. So this it is actually the CCA auto batch spooler algorithm runs, and it will create those batches onto this patient directory here. So this is the regular series. Of course, those individual series also will appear shortly, but that can continue in background whilst you can actually continue using CCA and do your further things. So after this coronary extraction, now what we have? So there's something, the important part, which is the coronary analysis. That's the important stage here, where you have to analyze for the plaque, or even for the coronary stenosis. All those things you have to do in coronary analysis. So that's why coronary analysis. Let's just let it load. Few seconds more. Since so many faces are there, so it takes time to load. And the algorithms have to run in the background, so it takes time, some minutes. Okay, there's no remote to lower the temperature.
No, there is no remote.
Oh dear. Okay, while we were talking, okay, this is the coronary analysis stage. So this has two modes. One is plaque analysis. As you can see, it is loaded by default. Of course, if user wants that, they don't want to do plaque analysis, their focus is more onto the stenosis or things like that. So we also have preference. Of course, the factory default is the plaque analysis, which is the default. But here in preferences, we also provide this default mode of coronary analysis. As if they want coronary analysis mode instead of plaque analysis, they can actually switch to that. So yeah, plaque analysis here, what you can do is at this point, you can see there's some space in between these two lumens, right? in inner lumen, outer lumen, vessel lines and the lumen lines. So if I place a seed point here, you can see, for example, if you assume there's some plaque over here, so you can define that, and the table also will be updated accordingly. You can what do you want to measure or what we are interested in, you can actually even these parameters, the values, all these things you can actually do through this button over here, which we provide, and even findings, how the calculation should be, Gaussian method, threshold method, all these things are also there in for the user to select, and even plaque historic, this one, okay, what particular histogram they want to see, all those things are there. Even there are some waves, curves that they can, the graphs they can visualize over here. So you can see there's some there's a drop down which actually gives user to visualize some curves. So yeah. Okay, so plaque analysis is all about this much only, that is findings, more it's related to, and if sometimes even the lumens that we have over here, if it is not defined properly, so they can edit that as well. So editing tools all are there, and of course here we can see there's a vessels list, the same vessels corresponding to what we saw in coronary extraction, same ones will reflect over here. And since RSE was the last selected one and also the confirmed one, you can see that this question mark is not there against RCA. Yes. Did you see that? It's not confirmed, so that's why it's confirmed. Others are unconfirmed, so that's why the question mark we are indicating. So let's go to now coronary analysis. Coronary analysis here now until ISP 12, stenosis is something which is very critically important analysis that the user have to do, the doctors have to do, because all these where the lumens, they are actually narrowing down in the vessel. So those points are called stenosis. So let's just let me show you one particular vessel over here. Load. So by the way, in USA there's one Society for Coronary Cardiac CT. So for that, there they have defined some rules and some formulas called CAD-RADS, Coronary Artery Disease Reporting and Diagnosis System. That's what the CAD-RAD stands for. So here you can see, by the way, in the straightened MPR and even in this curved MPR, there's a spot over here, which is very narrow, correct? Yes, that's called a stenosis. So there are many, I do have some studies where we can actually, there are multiple stenosis in particular single phase itself. So what we have to do now, what are these viewports here? This is the point where this particular stenosis will be marked. This is called, whatever is behind the particular stenosis reference point is called proximal, and what is in front is called distal. So here in this references, I can hide or show proximal, distal as for reference. And let me just come to, or if you want to come over here, right, at this stenosis point, all I have to do is hold control and do a click. The markers, they just jump to the stenosis point. So they, if for example, this LCX vessel is not that long, but some vessels which are really long and you have to scroll in the straightened MPR, so that will take more time. So they can actually do this jump action. So control and then click. That's a shortcut. So let's just do further. Now here in AVW 15. This is something which this CAD-RADS is something which is new, and something that along with that is this finding management. Earlier we were showing this stenosis calculations, the measurements until ISP 12, but there was nothing like this stenosis grading, CAD-RADS, all these things were not there. There was no finding management. This thing was not there at all. They can do all these analysis, but what they are interested is what is latest in technology. So this CAD-RADS is something which is new. So let's just save a finding here. Now at this point, you can see one button over here, save finding. I'm just going to click that. So at that point, it has actually marked a finding over here as F1 LCX. Now, if the reference point, now there are some vessels where the reference points also might not be good. Why do we need reference points? Just to compare that how the normal vessel should be versus where how the stenosis is. So that's how it helps, and that's where that's how they can calculate the grading also. So this you can see that this grading value over here, severity has actually appeared over here. This was not there until this stenosis was. I hadn't saved that finding, right? So that time this grading was not there. So this is actually calculated on the basis of this minimum diameter percentage over here. It is 75%, right? So 75% is between 70 and 99. So you can actually define some more findings for other vessels, and it can be somewhere like mild. There are many gradings over here, which is like mild, minimal, average, severe, occluded. Many are there. So let's just okay, let me just take one spot which is okay. This also looks quite 63%, which will be a little moderate. So okay, you can see that this finding actually it is not necessary that it is only for the selected cases. It is a consolidated finding list. Until AVW15 RFD release, this was before that, even when we were doing some validation releases. So at that point, this finding used to be only for the selected vessels. But this was one of the user feedbacks and their interest that they wanted to see all the findings together for all the vessels together as a consolidated findings. So that's why we made this finding list as a consolidated one, and so it's going to list all the vessels of all the findings of all the vessels. So let me just select one over here, LZX. So yeah, correspondingly you can see that this vessel list also has highlighted the particular vessel. So now comes the bigger part, which is actually important, is this finding summary. Now we have actually marked a couple of findings, right? Now they can be, here is where the diagnosis, the recommendations based on the CAD RADs is what we provide to report what their issues are and what these, since the severity is high, you can see that a dialog has appeared, this findings summary, where also we do provide some hanging protocols, how they want to visualize. Now this focus mode is specific for individual findings. We also have some overview mode related protocols, where you can see that the straightened MPRs of both of these findings is listed over here. But of course, in overview mode, you won't get to see the cross-sectionals. That's the difference. And of course, what you want to see along with this straightened MPR is this is something called SCCT map, or now we call it as segment map, where you can see this is like how where the aortic aortize that point, the further vessels, the branches, the LAD and the RCX, all those things, it is actually presenting like a map over here. So here what is highlighted is these findings point only. Now on the basis of where it is located, you can see that the segment over here, it is written, right? Which point at this LCX, it's a long vessel over here. So in the distal part of it, you want, is it actually the stenosis at the distal end or in the proximal end? So we can actually, if we want, we can actually change it. We can, change it. But of course, what it will do is that's it will highlight the corresponding ones only here in this. And if, for example, if I'm not satisfied with this stenosis grading, if I change something, so what we do as a mitigation, we are resetting we are hiding the value of the stenosis and minimum diameter, as because user is not convinced that stenosis value or the minimum diameter is correct. So they have actually quoted that the stenosis severity is actually mild and not severe. I'm just giving a worst case, like severe, and it can be a little up and there, but not so much. So yeah. So that's now if I make it as okay, I'll just clear changes. If I do it, it'll clear to what the actual value, as per the algorithm, whatever the value was. So yeah. And so in this one, you can see that this SCCT map you can maximize, and you can even rotate these volumes, by the way, inside. So likewise, you can even visualize along with that is if I want with the CMPR if you want, segment map with this CMPR if you want, you can do that. So this is the one simple layout over here I can talk about, and here you can see this is what is defined in the CAD-RADS. I can share with you guys the CAD-RADS document, the PDF, what the journal says. You can get educated with that. So what these are now, this at this point, if for example, if a scan is done after putting the stent, so at that point where the stenosis is there, even a stent is there, you can actually enable these options over here in this modifier. You can make it as a yes. And if the narrowing is too much and it's non-diagnostic, you can give yes for that. Or if there's any grafting, you're aware, right? If any vessel is totally gone, so some vessels from our legs are actually, yeah, that kind of an grafting, they do that. So if there is any graft vessel is there, so for that also they can do this. Or if there's any plaque, also any high risk plaque, they can enable that. And on that basis, some automatic suggestions is what is already given in the CAD-RADS journal based on what the stenosis is, what the severity is, and if there is any kind of these modifiers that you have specified. If you have anything specific, you can. This automatic suggestions is something which is given to the doctor. What they have to do, what diagnosis, what treatment they should do is provided over here. So they can, and even on the basis of what chest pain if they are having, if it is not too severe chest pain, it's just a stable one, then okay. Otherwise, if it is an acute one, so the suggestions also change accordingly. And if there's any ischemia, any plaque burden or anything like that, so you can see this here over here, it is suggested CAD-RADS category. This labeling, this is indication how what the doctor will understand that. If I, for example, if I add like as there's an ischemia I plus or stent S, it'll just add such indicators over here. So accordingly, and if, for example, even what CAD-RADS, these are CAD-RADS categories 0, 1, 2, 3, etc. So all these, if it is not 4A, if it's something like 4B, for example, they can change and they can accordingly they can decide, and they can then after that they can save it as a screenshot or an image series or send it to filming, reporting, or even we also have this copy to clipboard. Copy to clipboard, you can do Control-C also, or you if you are not comfortable using keyboard shortcuts, we also provided this button as copy to clipboard. Okay, so after that, save changes, and thereafter, yeah. So that's about this coronary analysis. And of course, here this method which you are seeing here is called coronary method, which actually is how it is presented over here. There's something called caliper method. Caliper method is where this stenosis point you can actually do it like I mean how we have calipers, right? That kind you can actually adjust, or we can present it like that as well. We can calculate on that basis also, but for caliper method, there's no this CAD-RADS stenosis findings is not there. That's why you can see that this grading is gone from this table also. It's applicable only for the contours method. Yeah. Okay, last stage is the functional stage. I think I have exceeded my time. If you guys fine, okay. Because the CT applications are quite a lot of them. So there are some more applications that I want to talk about, but they are also even bigger than this. That will take even longer time. But of course, since these are the most used applications, CT Viewer and CCS, so I thought that I'll cover only majorly these. Okay, so once this functional stage we have come, right, it is first it does is set phases. Here now, usually the diastasis is the 75% and end dystolic and systolic are 40 and 0 and 40% respectively. So it identifies itself and we can just say 0. If we disagree, we can select another ones from the drop down. So yeah, it is just calculated and the table also gets updated. There are various things which happens over here. What method we want, segment method, segmentation method, Simpson method, or which table we want to see, what graph we want to see. All these parameters we can enable, we can play around, and we can how the user is interested in. So there are various layouts also. Every stage has many layouts we have. So yeah. So Simpson method there also, and there's even defect assessment, which is part of a functional stage. If there is any defect in the card in the heart, so we can actually calculate through that also. So if there is any axis that we want to correct over here, like which axis is it's not correctly placed, we can change and we can do that. Or any contours they want, the contours, I'll just do this correct contours. You can see that this endo contour and epi contour. Yes, those you can even edit them, or any show papillary muscles if they are there. So those also it will show. Okay, let's just go to view result. View result will actually it will take back to the default tab, which is the functional analysis. Yeah, and here we then here again. So after that, it is LVRV correction is there. The same thing which we saw already. Defect assessment. So there are various maps in this defect assessment. Even the polar maps are there. Yeah. There are many layouts over here. So yeah, spoke wheels if they want. Yeah. So that's all about CCA. If you want to explore yourself, you can. There are some demo data already there in the demo data folder. You can actually play with them. CCA related, you can actually play with them. Yeah. So yeah. If you have time, I can actually cover one more application. But if you guys, I mean, it's lunchtime here in India.
We can continue again, ask them.
Okay. Any questions on the other side? Our teams have presented a lot, and I think I didn't get any questions in between.
Yeah, so just have a quick question. So
Uh-huh.
there is a caliper method. So in the calipers method, it is a manual or automatic?
It's manual. It's a manual
Okay,
one.
manually we have to select, right?
Yes, yes.
Okay, okay. Thank you.
Yeah, all right. Okay. Other than that, this TAVI is one of the most used. TAVI is actually transcatheter aortic valve implant. Now, these catheters, all these stents.
Full name once again.
Transcatheter aortic valve implant. Yeah. Yeah. So what this? Yeah. So what application? This is actually used where I mean, stent placing we do across so many vessels, even for, not only for heart, even the angioplasty and all that. It's done even at legs and where not. So TAVI, it is more for the aortic valve. Aorta, you know where it is. So that's where actually we have to place, because if at that point itself there's any kind of defect, and we have to do some treatment at that point itself where the blood flow starts, because aortic arch is the one which actually gives blood to the descending part of the body, lower part of the body through the aortic arch, and there are some branching which happens even to the upper part of the body through the aorta. Correct. So if there is any problem over here, there are blockages over here, so we have to place some catheters over there, stents over there. So this application is actually meant for that purpose, to plan how correctly it should be placed, because if when they are placing it manually without proper analysis, there are chances that that catheter might fall inside the heart chamber itself, inside the left ventricle or wherever it is. So instead of that, they should actually plan where it has to be placed. So you can see that there are some landmarks over here where this particular where the aortic area valve is actually starting over here. So right sinus AV and non-coronary left sinus AV, all these markings are there. You can landmarks you can just accept, or even these tissues also what they are interested. There are various tissues over here. So it actually the segmentation stage as usual is a common thing. Let's just go to the next stage where actually the real work happens, where each here now you can see this out over here. This is within the scope of this is where the implants are actually placed, the catheters. So they have to plan where this has to be located. So this also has various parts. The ascending aorta, which is the top part, and then the sinotubular junctions, sinus of Valsalva, annulus, LVOT. There are many names for them also. So if these are not positioned correctly, then it has chances that the implant might not be in the correct position, because the purpose is that because here is where you can see there are some flaps, right? 3 flaps are there for at this aorta point. If it is there, it is blockage is there, and if it is this particular implant is placed in such a way that that particular flap is blocked, it's not able to function properly. What its the main intent is, then this treatment will go wrong. So this has to be planned correctly. You have to position how that particular stent has to be, how big it has to be. All those things. Planning is the main purpose over here, basically. Unlike now in this CAD rides and all, we are doing the suggestions and things. There's no suggestions, but here we have to do the planning. What it has to be, where it has to be. Yes, please.
Also, we need the planning, the size of the valve need to take in account that it will not block the entry for the coronaries.
Correct.
Be aware of it.
Yes,
and,
right.
So be careful when you have TAVI issues. Be very careful to see that it's not about the measurement and it's not risky.
Yes, yes. Correct. These measurements have to be really accurate to substantiate what they want, right? This measurement table you are actually referring to, correct? The measurement has to be accurate, correct?
Yes.
Now here also what we want to visualize in this measurement table also we have some configuring options over here, like if it is contour based or elliptical, all these measurement types we have. So what we want to see on the table, what we want for each of these annulus, sinus of Valsalva. Now you can see that the measurements, like for example this the perimeter area and all, they're not shown for many of these now, sinotubular junction or all these. So you can actually customize as you want. If default is how it is most preferred, but if we are interested in more of these parameters, we can actually customize as we want. So, and this defect sizing is one of the most important part in this TAVI. Next is this last stage, which is actually just this access route assessment. So how the vessel actually goes through from this aortic arch all the way to the lower part of the body. So you have to mark where the aorta is and the left and right iliacs are. Simple. So here now, for example, this is where the aortic arch is. So I just mark this as aorta, first one, and then this is the right and the left one. So once I do this and accept, it will calculate and the layout will reload, and how we have which point we want to work on, if there is any narrowing over here or anything like that, any measurements that we want to define or any contour or anything, we can actually do that automatically. These calculations, these reference lines also are available, where instead of drawing the ROI yourself, if I do a measuring myself through drawing line or anything like that, that will be really time consuming. So we do have such tools also which actually does that, and then you have to add these measurements onto this measurement table. So this one measurement I just did. Another one now, even recently we also had this one more RFC, which in this TAVI application is firstly that this particular line, which you can see, right, this was actually not moving through. We cannot drag it. We can actually just scroll through, but the user wanted that. They wanted to drag it themselves, both in straightened MPR as well as this is the curved MPR. This is a straightened MPR, as you can understand. So other than that, next RFC which we did in this AVW15 is, you can see that this label, it is showing us the vessel name as L1 for both left and right side iliacs, correct? Aorta and right iliac and left iliac, both it is at L1. Why? So instead of, because this is an old feature and some may still prefer that let it be same name, kya farak padta hai? What's the difference? So we do have option called rename measurement, so they can just change any name they want. We can, instead of calling it as L1, both L1, they can make it as R1, L1 or whatever they name they want. They can just make it as R1 or anything they want. So yeah, this is the last thing, which is TAVI. Yeah. Any more applications that you guys are interested to know? Or you want to break? Okay, the folks over there over Teams, are you guys also, do you guys want break?
A 5-minute coffee break is enough for us. We only have lunch
Okay.
in a few hours.
Okay, yeah, all right. Okay, I think anyway, other than these 3 applications which I spoke about, CTV card, then CCA and TAVI, these are, others are, I mean, we don't get so many customer complaints from those sides. Another important application is this COPD application. That is the chronic COPD is one of the most important issues and one of the very common health issue. Even in USA, it is that is obstructive pulmonary disease.
Yeah, chronic obstructive pulmonary disease.
Yes, correct. So it's actually like, we can say it's the big daddy of all these asthma and all these lungs related issues, where it is more of emphysema and bronchitis and all that. So COPD application is used for that purpose. You can probably, if you don't have so much time, because it's quite a big application that I have to go through. If you want, you can play around yourself and you can learn, or if you want, I can just do a quick presentation now. Shall I? Okay. Okay, then. So COPD, as since lungs, we have that is inspiration and expiration scans. So that is when the lungs is full and when all the air is out. So at that point, so these 2 scan types is what these images are used for COPD analysis. So I'm launching a bookmark for the reason that actually first stage is segmentation, and segmentation of it actually does segmentation of the airways, then the lungs and the individual lobes that are there in the lungs. So that's that actually is little time taking, and if I launch more than 2 series, so it will take even more longer time. So that's for that reason I saved a bookmark. So yeah. So you can see that the airways are there, lungs and lobes are there. Here also we have some editing tools. If you want, where there's this, where the airway tract starts, right? That's called trachea. So first thing where, I mean, the editing tool where we can correct is, say for example, if it is not correctly scanned, or if anatomy is not identified correctly. Sometimes I've seen that for COPD, in COPD application, if by chance the scan which is used is actually below, that is the lungs are not full and it's more actually for a thoracic scan. So at that point, maybe a little bit of other parts of the lower parts of the body gets identified as airways. It's actually quite a possibility. So to correct all those, where we have to, because actually this segmentation actually happens from the lower part of the body. So if it has identified any lower part of the body where there's some air, it might think that there's the airways. So we can actually do this correction. We can do a mark trachea and we can correct that. And anything other than that, we can do that. Even the editing of lungs, sometimes even the left-right lungs. Earlier we had some tool called mark left and mark right lung, but nowadays we don't, because early when this actually COPD application was came into existence from ISP 7. ISP 7. That's when, in fact, I also joined ICAP. So I was the one who was completely leading the COPD testing. So that time, this had this feature, the option called mark left and right lung also. Now we've completely removed that because anyway, the left and right lung identification is most of the time it is very efficient and it is able to recognize what is left and what is right. But of course, if it is any kind of like a prone scan or anything, prone scan are actually not allowed in COPD. If you launch a prone scan, it will throw a prompt that it's actually it's not supported. So only these helical supine scans are allowed. Not even this decubitus scans also, it's not recommended. It should be a supine scan for lungs. So yeah. So because when we are when earlier those options were there, mark left and right, for testing we used to do the ulta, do the upside down, marking the right as left and left and right. Such kind of testings also we have done. We have done like even since we have this erase option, we used to erase the whole thing and we used to see how it works. Lots of testings we had done. So yeah, edit lung is that much, and this edit lobes is there where if these fissures which are there in between these lobes, if it is not marked correctly, so there is chance that upper lobe and lower lobe, middle lobe, it might overlap upon each other or things like that. So that's about segmentation stage. Here also you can see that since I loaded 2 series, right? So we can actually do a comparison also. So yeah. And okay, next stage is second stage is called lung density, where the analysis for emphysema and even the air trapping is done over here. Now during COVID, this was one of the most used applications.
Yes.
So we added some more algorithms to highlight the COVID, the virus more, all those pneumonia virus and all that. So it was actually for have such sort of studies where we got some test data for that purpose. So it was full of those were nightmare days we had. Okay, yeah, so this lung density. So here this custom preset was the one, those algorithms were the ones which were used for this COVID analysis. Other than that, for measuring this lung density, we have the percentile mode and threshold mode, and what threshold we want to set to analyze or things like that. We can even this noise reduction, if there's any noise in the scan, we can do that. All these options are there, many things. Air trapping is where, I mean, the inspiration and expiration. I think my mistake that while preparing yesterday, instead of deleting the sharp ones, I think I deleted both the expiration ones. So anyway, so it is it'll show both the inspiration ones, but never mind. Yeah, it has. That's why I see it's it has confused and it has both the inspiration. One of them it has actually identified one of the inspiration as the expirations series. But that's okay. Yeah. So here also you can, I mean, this is calculating on the basis of inspiration and expiration. So all the measurements according to that, it is showing over here. You can even draw ROIs, 2D ROIs. So ROI you can first place in the end inspiration and then second one over here. So accordingly the table updates. So table also here we have some volumetric measurement which is related to the volumes over here, and actual measurements is for, of course, the 2D ROI. So even for the lung density, we have same kind of 2 types of tables, volumetric and actual. So volumetric, now if I draw a volumetric 3D VOI, so those gets added under the volumetric measurement and ROIs gets added into the actual ones. Now you can see that the volumetric one is added over here. Yeah, so it is indicating over here as well. Okay, so lung density is this much. Next is where it is talking about the bronchitis and all that too. So here is where the airway extraction we have to do. We have to identify these branches, which is which. So say for example, let me just place a marker over here and I'll just do a right click. A labeling window will appear Now, what name it is, name for this, we can, if whoever is working on COPD application, the doctor, if they are experts, they will definitely be able to identify. But it's if somebody is new and they want to learn, or for research purpose or anything, we have a map over here as a reference. So for example, if over this branch, if it is an intermediate bronchus, I'll just mark this as a right intermediate bronchus. Anything like that, we can just mark a few, and then thereafter we can. This is a right and left main bronchi. It is a. Okay, never mind. All right. So here also, if the center line is not proper in this curved MPR, we can do that editing also. We have editing tools for that as well. This extraction stage is just this much. Other things, of course, this is the regular tools and what we want to visualize. Show or hide this center line, cursor, whatnot. Now here we also have a, this is of course the volume, straightened MPR, and we also have cross section over here. This is a cross sectional, and that's the regular axial MPR. Last stage is, here is where the airway measurements happen. So at what point, if there is any particular airway, the bronchitis that they have pointed out, so they can just place this measurement for defining the position. So individual position, or even these where this reference, the whole length is there, what they are interested about. So this also wall thickness, all these calculations they get to, and we can what measurements they are interested in, what parameters they want to see. All of these we have given various options. We can even, by the way, all even in that is even in segmentation stage also we have a table. Lung density also we have table, and here also everywhere we have given this copy to clipboard option. Copy table to clipboard. So those tables can be exported to MS Word, Excel, and even a Word document, or even an Outlook draft if you want. It just copy paste like that as a table. So you can do all that with this, and this is just that is along the center line it was. So you can see that this airways which we had saved, marked over here in this last stage, right? Remember? So they are listed over here, the same airways. So now that was along that, but if we want to mark airways for inspection at certain points ourselves, so we can just place seed points, and it actually keeps these measurements based on airway measurement, actual based it is. So all these actual images which they are. So you can see this. So this is about this airway measurement. Last thing which is there in COPD is this endoluminal view. You can the same thing which you can visualize as endoluminal, simple. And if you want, you can even see it like a flow, the flow of the airway center line along the volume. Yeah, that's it.
Do we have time for the trauma application?
Trauma will be presented by the next presenter, by the way. I am not going to be presenting trauma. I'm done with my session today.
Okay.
All right, then. I'll make a move then. Any other further question anybody wants to ask? Any questions?
So what we are measuring in the lungs, like in the COVID cases, there is a like attenuated tissue in the lungs, which is alveoli. So there is no exchange of CO2 to O2 that is happening. So what we are measuring inflammation in the lungs, or like in attenuated tissue. What we are measuring?
It's just the inflammations that we are measuring over here. Whatever, like for example, emphysema or any this low attenuations, as you are saying. So all those things is what it is measured in this lung density over here.
Okay. So the overall lungs density is reducing in the COVID cases. So we can find out that this is the COVID.
Correct.
Also, there is emphysema, that some of the lung tissue is damaged, and you can see it as a very black area of the lungs, and this is for smokers more.
Yeah.
Yeah. Yes. Correct.
Okay.
Okay then. Any other questions? Anybody? Hope my session was informative.
Yeah, it was.
Thank
Yes,
you.
it
Thank
is.
you very
Yes,
much.
it was.
Yes. Thank you
Thank
so
you.
much. Thank you so much for your time.
Thank you. Next session is going to be in 30 minutes, or does anyone know?
Let me just see the schedule. What it says.
It was in 30 minutes.
Yeah. Okay.
All right, then I'll inform the next presenter to be here. And okay, 2 p.m. IST. All right then.
Okay. Thank you.
Thank you so much. I think,
Thank you.
I hope I give you some time for lunch, I guess, the folks in India. All right, I'll also head for my lunch as well. Okay. All right then. Thank you.